It's interesting to think about how we're all talking about vulnerable populations today and moving into language across the lifespan as one of your special interest groups. Today, I'll be talking about language and neurodegenerative disease. Loss of words, not heart. So I get a little jazzed near the end of my talk. So I'm going to zip through to that part because today's talks have all been really charged and have made me feel like my advocacy warrior and my heart's going crazy right now. So I want to get you jazzed about advocating for this population as well. My name is Makenna Green. I am a clinical speech-language pathologist with expertise in dementia care. I'm also a PhD in health sciences candidate. Hopefully I will be done with that dissertation and join the PhD club here in just a few months, right? I'm also a clinical supervisor in our graduate SLP program, so I supervise our grad students in our university clinic. I'm also an adjunct instructor in neurodegenerative disease and assessment and acquired neurological disorders at NIU and Western Michigan University. When we talk about dementia, because everybody's knowledge levels is a little bit different, and my doctoral work is on quality of life, strength-based treatments for people with dementia, in addition to how do we implement service learning and engagement with this population when educating future healthcare professionals, not even just speech-language pathologists, but all of us, right? So in the name of that, today is going to be a little bit more educational. Dementia itself is an umbrella term. When we hear the word dementia, we kind of think, oh, that's a condition. But actually, it's an umbrella term used to describe multiple specific diagnoses underneath that umbrella of dementia, which is loss of our neurons in our brain, right? So some of these more specific diagnoses that you may have heard of include Alzheimer's disease, Lewy body dementia, frontotemporal dementia, and primary progressive aphasia, which has been more in the news lately with Bruce Willis, right? So we've all kind of heard about that. Again, dementia is physiologically characterized by degeneration of neurons in that middle part of the brain, in the hippocampus, and then that spreads as the disease progresses. Symptoms are wildly heterogeneous, but we can kind of bank on memory is gonna change, right? Language is also likely to change in this population, and thinking skills change. How we process, how we plan, how we organize, those skills are likely to change as well. I have been treating people with dementia for a long while now, and 3 people with Alzheimer's disease are not going to present the same way, okay? Nobody is a textbook definition. And I think that's important when we go into engaging with people in our communities with any type of neurodegenerative disease at any stage. We have to understand we can't go in with expectations. These are some of my family members. That first one does have my baby. It's important to mention, when we think about the whole population, the healthcare landscape is gonna be changing here really soon, okay? The population of those 65 and older, neurodegenerative disease or not, just regular population, is expected to rise from 58 million now to 88 million in the next 25 years. So we're going up by 30 million. So the population of older adults, those 65 and older, is expected to rise precipitously. And the healthcare landscape and infrastructure is not ready for it, nor are our future healthcare professionals to deal with this surge of a really vulnerable population that needs support and help. The prevalence of those with dementia pathology in people over 85 is over a third. We can say, yeah, older people are going to be a lot more of them here in 25 years, but knowing that those who live beyond 85, it's a third. It's not a small percentage. It's over a third. So when we think about dementia and language specifically, we break up dementia into stages. That way we can kind of conceptualize what to sort of expect, right? In our early stages of dementia, we might meet somebody and not even think twice. We might not even consider that something is going on or that their brain is changing in any way. What you might notice is they've got that, what's that word? Word finding, what's called anomia challenges. They might make excuses for it. Oh my God, I didn't have my coffee this morning. I can't find that. What's that word for that thing? And that is happening more and more frequently. In addition to that, they may have more difficulty with abstract or decontextualized language concepts. So if you're telling a joke that's more complex, if you're giving an abstract narrative about something that they don't really know about, the ability to follow that might not be there. But man, the ability to cover those deficits up in the early stages is really high. This early stage of dementia or minor neurocognitive impairment, the engagement with these individuals, it's something to note that those excuses, those covering up of deficits is really pronounced, and it can make the emotions and feelings around that come up. Fear is something that comes up for people here, and not knowing what's happening. Early diagnosis and support is key. When we move into the middle stages, we have the same issues that early stages have, but we also have reduced topic maintenance, so that ability to go back and forth with somebody isn't quite there. The pragmatic rules, the social rules we all have of like we have to wait until they're done talking, those are preserved for quite a while in dementia pathology. But just the ability to maintain that line of topic is starting to reduce. And they have fewer ideas that they're able to generate independently and share in a narrative. When we move into later stages is when we see strong impacts on language functioning. There's lack of coherence in message, loss of meaning. So it could be that they're saying true words, but they don't make sense in their narrative, or they're making up jargon or words on their own, okay? And in addition to expressive or what they put out into the world with their language, there is a dramatic loss in comprehension. So if we tell somebody to do something, they're not going to understand what the expectation is. But what's preserved longest in dementia? We see that syntax, or the ability to produce sentences, those sentence structures, the rules for sentences, right? That stays for a long while. Phonology, or speech sounds, stays for quite a while. Reading ability is also another skill that's preserved later into dementia. Now, the understanding of what is read, different story, but the actual mechanics of reading maintained for longer. And then emotional connections, right? We are able to feel and sense love and social connection well into dementia pathology. And that is linked up to language, right? We're going to talk more about that in a bit. When we think about those changes in language, we can't talk about them without talking about neuroanatomy in some way. So right, this is the left side of our brain, and that's our language center. We've got our temporal lobe. This is where our Broca's area is, where we talk from. All of our language understanding is there as well. Our hearing centers are there. If we're to slice the brain in half and go right into the middle, this purple structure here is the hippocampus. And this is where dementia pathology, or that neuron degeneration, that neuron death, typically starts, deep in the middle of the brain. Then, as dementia progresses, spreads out, and then begins to affect these side parts of the brain moving forward. But it also explains why certain skills are spared for longer, right? Or it also explains why, depending on the phenotype, the dementia type that someone has, they may present differently. Someone with Parkinson's-related dementia, where the pathology begins further back in the brain, middle part of the brain, in the basal ganglia, their language is typically preserved for much longer, okay? Neuroanatomy is an important distinction to make when we think about language and the impacts in people with dementia. We also have to understand someone's brain and brain degeneration, once again, is not going to look the same between two people. We have expectations, but we think about the unique system of each and every one of our perfect brains, right? And even the way the cells die is going to look different among each of us. When we're talking about the brain and language, we also have to talk about cognition. We cannot disentangle language and cognition. They are inextricably linked. right? So we need cognition. We need memory skills in order to maintain our semantic memory, our understanding of, oh, this word means this, and this word works here, and that's memory. That's cognition, but it's linked up to language. So these semantics, these words are lost, much like memories and dementia, because once again, language and memory, language and cognition are linked. When we think about language, I want us to spend time today thinking about it differently than what our connotation for it is, okay? Language is communication. Language is not just isolated to expressive, receptive, what we put out, what we understand, what we read, what we write. It's connection. And someone with dementia, regardless of if their language, the connotative language has changed, they still have the right and desire for communication, connection, and engagement. So we think about the ethical considerations here. We think about beneficence, doing good, and autonomy. Cohen Mansfield is a heavy hitter in the dementia world, and she has gone through and looked at different ethical considerations and human rights in other areas of study and applied them to dementia. And I pulled some of my favorites here for you today. The human right to receive and express love. How valuable is that? People with dementia deserve to communicate their love, who they are as people, and receive it back in ways that they are able to, okay? So again, language, the understanding of what we think of as language may change, but there are so many ways we can communicate beyond that. Language may be limited, but love is not. So your role in this as community stakeholders, as future healthcare professionals, as family members, as perhaps future caregivers, right? So I wanted today for all of you to walk away with some tools. When you're interacting with someone with dementia, knowing that engaging in something they loved, something that's salient, that doesn't have true language demands, but offers opportunities for communication. This communication can be expressed by facial expression, right? If you know me, you know my face says it all. I don't need words. We can communicate safety just simply by our face. That is nonverbal language. We can say to that person with dementia in late stages, "You're safe with me. You do not have to fear," just by how our eyebrows are raised and the smile on our face. Respectful and appropriate touch, engaging, closing the gap between someone can be really meaningful in this population when it's received well. And reminders of who they are. And once again, this doesn't mean, oh, you used to be a teacher. Telling them that. It is engaging with them in something that's related to their personhood. When I was working in a facility, a memory care facility, there was a woman who was a teacher for 40 years. And she was someone who had no discernible or intelligible language to produce. But a little kiddo was visiting another family member there and came and sat with us. And I had a whiteboard with some shapes and a dry erase marker. And that woman grabbed that whiteboard out of my hand and started talking to the kid and teaching to the kid, pointing to shapes, engaging, eye contact, all of this beautiful nonverbal language and connection, right? If we can support those activities, we bridge the gap and can communicate, right? When we think about autonomy, people with dementia have a right to respect. Communication by any modality to support that respect is necessary here. If we're going to say, hey, we're going to run to the bathroom here, that's a lot of language for someone to understand. Using visual aids, pointing, gestures. We cannot rely on what we conceive of language alone when we work with this population. They have the right to be taken seriously as well. People with dementia may utilize other behaviors as their language of choice as disease progresses. We have to take these communication behaviors seriously in order to find out what they need. What are their wants, needs, ideas, wishes, right? They have their right to beliefs and secrets, regardless of how far into disease progression they may be. And they have the honoring of their own self-determination. Your role in this is not to infantilize the person with dementia. How you speak to somebody should have the weight of speaking to somebody who has lived decades of life before you have met them. And unpacking those behaviors as language and communication. We can't just throw our arms up like, oh, they're just yelling, or oh, they're just not doing this, or they're just not listening. This is communication. And we have to bear the communication responsibility. When we think about caregiver support, caregiver burden is a huge issue in this population. Family members, peers, people who are engaging with the person with dementia have mental and physical impacts. Your role in engaging with people who are caregivers is providing education on communication strategies that you've learned here today, if able, and if someone's open to it. Knowing community supports like your area agency on aging is a wonderful resource to share with people, okay, and having just genuine patience. When you might engage with somebody in the community, utilizing focused communication strategies can also be a useful tool. Say you find somebody who's turning from that early stage of dementia to middle stage, but they're still driving and they're stuck in the grocery store. That's my point of today's talk, to give you something, regardless of where you end up, regardless of if you do not professionally work with someone with neurodegenerative disease. These strategies can be very helpful in engaging with somebody in your community and supporting communication and language across all brains, all people, all populations. Thank you. Yes. So the question here is, what is the current status of the research? What are we doing to deal with this huge influx of people that are likely to develop dementia, that 30 million plus number that's going to hit us here in 25 years-ish? I think we're at a place now where the alarm bells are being starting to be heard. Okay, so the Alzheimer's Association right now is advocating, but our actual infrastructure itself is what I'm the most concerned about. So, I come from experience of being a CNA all through school. So I was a CNA in some of these places, in addition to just engaging in now the research and being a speech pathologist in these areas. And I was paid, I think, $8 an hour. That's a huge barrier. These nurses also. And the staffing concerns and the turnover rates in our memory care facilities, assisted living, supportive community environments, we just don't have enough, right? And so what that means is that individuals, okay, they're gonna stay home. What about community supports? I have another publication that investigates the policy landscapes for informal family-based caregivers. And access, we talked a lot today about access to policy supports, funding, things like that is really low. They exist, but the ability to access that and utilize it is pretty poor, especially among vulnerable populations. I'm hoping in the next 10 years things change. The last administration started to push forward a lot of different grants and funding, but similar to both of your talks, I'm just not opening the news. The question is, I feel the statistic is those who are 85 and older, there's 1/3 of that population is likely to develop dementia. Is that number going to increase as the years go on, or is that number fluid? That's the most recent number from the 2024 Alzheimer's Association stat report. I wonder though. I mean, what in the last 25 years that we've all been exposed to, the ways, but also in addition to that, we think about advocacy, brain health. We think about the neurodivergence and neuroaffirming movements that, people are kind of up in arms about, like, oh, there's so many more kids diagnosed with blah, blah, but it's just greater understanding, right? So it's not a far leap or a far line to draw that perhaps our dementia diagnoses will also increase because we will be better at early identification. So when we as like speech pathologists can get in with somebody in early stages, mild neurocognitive impairment, we have a much greater likelihood of staving off disease progression and reducing overall decline across the course of dementia disease. So I am so hopeful that that happens and that we get more people engaging in brain health, therapy, getting referrals. But once again, if that happens, we need the infrastructure to support it and well-educated future healthcare professionals to do it. The question is about early signs of dementia and other factors, lifestyle factors, other age factors that may mirror some of these early symptoms that I mentioned. Well, one, to speak to brain health, good sleep, good diet, reducing stress, all of these things are great for your brain and they help reduce dementia risk, right? However, I think I got like 4 hours of sleep last night. I was stressed out of my gourd. I've got, my 4-year-old at home, not trying to write this. And so I do understand that there's a degree of normalcy, right? And you best believe I have anomia all the time. But what does that mean, right? There have been some unique studies, and actually one of a long time ago now, my undergrad thesis work actually investigated narrative samples, and now we're finding some new studies also investigating when we look at, it's not the one-off like, oh shoot, what's that tip of my tongue word? It's going to hit me at midnight tonight, that experience that we have all had regardless of age. But it's the ability to form those cohesive narratives in richness. So as we move through dementia stages, right, like I mentioned that cohesion starts to change, our ability to kind of maintain topic, but there are specific signs among our lesser used word classes like verbs or different morphological endings, things like that, and how they are used in complex syntactic structures that may be utilized in the future as early identifiers. But brain health is so important, like reducing your smoking, don't smoke, don't drink, reduce drinking, things like that, eating a non-inflammatory diet, all of these things. And also, you're all here learning. Learning is one of the biggest protective factors for your brain. Continuing to learn, continuing to practice those skills in your brain and flex it. Your brain's like a muscle, so I'm constantly saying that. Your brain's a muscle, work it out. I always go like, man, I guess hopefully I won't have to be too worried because my brain, I'm like, what degree is next after this one? So the disparities in brain health, just even having, it's a privilege to even talk about brain health, right? I have the mental energy right now to be able to expend on thinking, man, I really should stop eating French fries and eat more lettuce. I have access to arugula in my fridge right now. We have food deserts. We have these populations that can't access schools that they need. I mean, there are bigger fish to fry. So you think about the parents that we've talked about earlier today. Do those parents have the mental energy and the ability and the access to be even thinking about this? I think what's challenging right now is that literature and the community discussion about dementia is just starting to change in this generation. I mean, it used to be called old timers, right? Fairly recently, like I recently worked with a care provider who still called it old timers. So we are just at this first generation, second generation of understanding the neuropathology behind it and how it changes, that we know it's not a normal phenomenon anymore. Normal aging might have slower processing speed, less working memory stores, but period, like that's kind of it, right? There isn't this huge pathology that's old timers. And so we're kind of the first and second generation. So though your question is super interesting and good, I don't have a great answer for that.